Hi, everyone, and welcome to our panel on Black maternal health. My name is Shalon. I'm a lactation specialist here at Brookdale Hospital, and I'll be your moderator this afternoon. First, I wanted to give a little background on Black maternal health and the history, and then we will introduce our panelists and go forward with questions. Black maternal health refers to the health and wellness of Black women during pregnancy and childbirth, and the racial disparities in maternal health outcomes. The history of Black maternal health in the United States has been marked by systemic racism, discrimination, and a lack of access to equity, to quality healthcare. Despite advances in technology and knowledge, Black women have consistently faced higher rates of maternal morbidity and mortality compared to their white counterparts. This disparity can be traced back to the enslavement of Black women who were subjected to forced reproduction exploitation and medical abuse. The legacy of this systemic oppression continues to impact Black maternal health today, with Black women still facing higher rates of maternal mortality, complications, and unequal treatment within the healthcare system. Addressing these disparities and improving Black maternal health outcomes requires acknowledging and addressing the systemic barriers that exist. Now we'll go on to our panelists that will hear. I'll start with, they'll each give you a quick bio of who they are, introducing themselves, and we'll start with Dr. McCullough.
Yes, hi, good afternoon, everyone. I'm Dr. Cyrus McCullough, who is chair of the Department of Obstetrics and Gynecology and also maternal fetal medicine specialist. I've been practicing this area of high-risk obstetrics for the past 30 years, and that's our primary focus here at Brookdale Hospital and One Brooklyn Health.
Okay, and then we'll have Ms. Wooler.
Hello, everyone. My name is Ms. Willer. I'm a certified nurse midwife at Brookdale Hospital. I was a registered nurse for 5 years prior to that, and I just recently received my doctorate, Doctor of Nursing Practice at Frontier Nursing University. And maternal mortality is one of the topics that we discussed a lot while I was in school. So I'm very happy to be a part of this panel tonight.
And Roxanne.
Hi, I'm Roxanne Monroe. I'm a licensed master social worker. I'm also CLC, and I'm the director of the Healthy Families program here at Brookdale, which provides home visiting, evidence-based home visiting services to families with children 0 to 5 in the Canarsie, East Flatbush, Brownsville communities.
Thank you. And Ashley.
Hi, I'm Ashley Ornstein. I'm registered nurse and international board certified lactation consultant. Thank you for having.
And finally, Jackie, please introduce yourself.
Hi, thank you, Shalon, and thank you to our panel today. This is a great opportunity to move the needle on maternal child health. My name is Jacqueline Barley. I've been with Brookdale for almost 10 years now. I'm director of planning and now part of the strategic planning group over One Brooklyn Health. I work with my colleagues here as well as, folks up and down the leadership chain to identify need and to seek the funding that we need to support our infrastructure, our programs, and a whole host of issues. This one being one of them, maternal child health. It's great to be a part of this panel.
Thank you so much. So now let's get into some questions. Dr. McCullough, I will start with you. What are your thoughts as a Black provider to the responsiveness of systems of care to meet the needs of Black brown women? And to that end, tell us what you've done at Brookdale to try to meet those needs.
Okay, so it's very well known that the system is not geared towards providing the quality of care women of color need. And as a result, there's significant deficiency in addressing the issues surrounding maternal mortality and morbidity. There a lack of health insurance. There's really a paucity of quality health care, primarily in the neighborhood where women are disproportionately dying in childbirth or complications from pregnancy. And health has undertaken some programs to try to address the issue of high mortality and morbidity in primarily African American as well as women of color. And those interventions that we are currently doing includes new programs such as centering in pregnancy, where women are seen in group practice and they're able to interact with each other and bring issues to the fore that may be affecting them during the pregnancy. We also have a robust midwifery practice and here at One Brooklyn Health, Brookdale Hospital, and we also looking to expand our doula services to our community. So those are just a few of the things that we're currently doing to address the issue. There's also a program that we have on the that we're starting, which is a pilot program to visit to see if we can address the issue of maternal mortality and morbidity there, since more than 50% of maternal death occur after the day of delivery.
Thank you very much, Dr. McCullough, for answering that. Thank you so much. That was very helpful. Roxanne, the next question is for you. So we know you work with Healthy Families, and we know that Healthy Families is an evidence-based home visiting program. What do you do to ensure that the service you provide through Healthy Families is culturally responsive?
So, you know, Healthy Families hires paraprofessionals, so staff from the community who are knowledgeable of the services in the community, and we try our best to hire staff that look like the target population, and even in our interviews, we're asking questions to make sure that the staff have the capacity to build trust with families, that they have you know, the ability to be empathetic, that they're culturally sensitive. We use scenarios and questions to bring these qualities out. So in addition to, you know, having the minimal educational requirements and knowledge of parent-child interaction and child development, it's really important that they're able to build these trusting relationships with families in the community. We also do a cultural analysis at least annually, where we're looking at the demographics, the social factors in the target population. We're looking at our service population to make sure that we're addressing all of the needs in the target population. And we're also looking at our data. We're looking at our acceptance rates. We're looking at our retention rates to see if there are any trends with specific populations, whether it be Black population with Hispanic. We make sure that we have staff that can speak the languages that are represented in the community. And we also do surveys. We do surveys every year of staff and of families. And in those surveys, we're looking at whether or not staff have the equipment, whether they have the curriculum that they need to meet the needs of the families that they're serving. And we're also asking families about the services that they're receiving. Do they feel like it's culturally responsive? Are their needs being met? And then we use that data to come back to the staff and brainstorm and try to find ways to address issues that we may have identified. But we involve the staff and the families in decision-making and bring that information back to our model developers, who can then use that information to make changes to best practice standards as needed.
That's great. Thank you so much. Ms. Willard, this next question is for you. So as a midwife, what are the things that can be done to address the systemic issues that exist to our Black moms and babies? And to that end, how does a program like centering make a difference?
So first question, of course, having providers that look like the population is an integral part of the patients feeling comfortable with talking to you about pretty much everything. I tend to get really personable with my patients, and I don't try to rush them out of the office. I pretty much listen to them because a lot of them have a lot of social issues that also correlates with their pregnancy. And they look to us, especially if we look like them, and to be able to communicate those needs that they do have. And in terms of centering, so I'm very new to centering, but I've had patients come in and requesting centering, finding out that finally Brookdale is back with the centering, and the fact that they love it. One patient said they love it because of the food that they offer, but aside from that, they like the group setting. They like the fact that they can relate to other people that have pretty much similar situations going on, whether it's issues with other children at home, difficulty with breastfeeding, and to see that other people within their same gestational age is having those issues, and they could feed off of each other and learn different ways to cope with whatever situation is a good thing for them. So centering is something that they really look forward to, and is a good practice for a lot of them.
Great, thank you so much. Ashley, this next question is for you. As a lactation consultant and registered nurse, can you tell us what it means to be a baby-friendly? I know that that's something that recently got the designation. And the second question to that is, why is it important, and what are the impacts of being baby-friendly designated?
I'm sorry, I didn't hear the beginning of what you said.
Sure, that's fine. As a lactation consultant and registered nurse, can you tell us what it means to be baby-friendly designated? We know that that's a designated recently received. And then to that, why is it important, and what are the impacts of being baby-friendly designated?
All right, so our hospital, been working really hard to be designated baby-friendly since 2016. So what does it mean? It means for our community that we provide the highest standards of care when it comes to infant feeding and breastfeeding education. Following the 10 steps of successful breastfeeding, it really incorporates us getting to know our patients and families earlier on, really engaging with them, finding out what their goals are, their infant feeding goals early, and really building that rapport. So, we can actually address some of the concerns they may have as our midwife, what Ms. Willard said, and of course, as Roxanne, we can address these issues and get them the help that they need, so there are less barriers to meeting their goals. And we, incorporate the families in this. So why this is important for breastfeeding? Because, breastfeeding is one of those things that is essential. It minimizes many risks, such as breast cancer in women, ovarian cancer, metabolic issues, increased risk of diabetes, heart disease for the women, and for infants, it, decreases the risk of ear infections, sudden infant death syndrome, otitis media, which is ear infections, and GI issues, so many different things that can be avoided just by breastfeeding your baby. So with this 10 steps of success breastfeeding, even though a mother may choose or not choose to breastfeed, she is gonna make an informed choice, because we provide this education from them from the time that they find out they're pregnant. And we, offer the skin to skin immediately after birth, where they get an opportunity to bond with their baby directly after having their baby, because the mother's body is the the mother's body is the baby's natural habitat. So when the baby comes out and does skin to skin, it really increases that bonding, which benefits and grows that that bond between a child and their parent, which is essential, especially in high-risk communities, where attachment may be, an issue, attachment relationships, or even, opportunity really to, gain that empowerment and confidence, right? So we start that early with the rooming in. And what is this is minimizes the disparities and the comorbidities that occur within that period, because they get this information early. We build that rapport. They're breastfeeding exclusively. They have less of these issues. And then we continue to support them after discharge, which is a part of the 10 steps of successful breastfeeding. So we are guided by Baby Friendly USA. And because of that, we are held accountable. And through that, it ensures that the patients that come here will receive this high level of care. And we're really proud to provide this to our communities, because it would definitely close the gap on the issues that we have within the Black and African American community.
Thank you so much for that answer. Appreciate that. Okay, this next question goes to Jackie. With Maternal Child Health Initiative, we know that that's what you work with, and we know that it's inclusive of healthy families, centering, which are two things that we just learned about, along with Healthy Steps. Can you give us a little bit more information on what Healthy Steps is, and just an overview of what are some of the things that's happening in maternal child health?
So I feel it more appropriate to, I'm going to answer your questions, but more appropriate to just give you an overall history of how we arrived at the Maternal Child Health Initiative. And it's going to put all of our conversations in perspective. So in 2020, the year of the pandemic, we were just coming off the first round of COVID. Roxanne and myself, I pulled together Dr. McCullough, Dr. Fradkin, and we got together and decided that there was all the conversation going on about the glaring disparities that COVID showed in the difference in health between what we were getting in the communities that we serve and the rest of society, rest of New York. It's well known that we were ground zero for COVID because we had so many pre-existing conditions in our population. So that got on the radar that, the negative trends that are impacting African American communities throughout the country, that got on the radar. And foundations like Robin Hood, who's the funder for this project, the Maternal Child Health Initiative, they engaged us in conversation. I reached out to them and said, how can you help us? How can we pick an area where we can have the most impact? And because we were already having discussions in-house about maternal child health, we came up with a plan, presented it to them, and they were very willing to now look at serving African American communities in a different way. Prior to that, they funded us for obesity, funded Roxanne's Healthy Families program, but we engaged them to get them thinking much bigger, that they needed to really have a view of this problem that was holistic and not just funding one program here, another one here, piecemeal. So they gave us a planning grant, brought our team together in-house. We also engaged some staff from SUNY downstate. And we came up with, we were given a planning grant of $500,000. We did the first planning year, we had to do an assessment of the system, look at the processes we have in place, do an assessment of findings that are out there, things that are impacting how the bad outcomes for maternal child health. And out of that, we've come up with a plan on how to move forward. So we're at a phase where they've given us funding for an implementation grant, and our theory of change is underpinned by 4 or 5, key areas. We're looking at strengthening programs like Healthy Families, Healthy Steps, and centering pregnancy. We're looking at educating both internally and externally, clinicians and frontline staff on how to, make them aware of the problem of maternal child health and how we can come about and come together and design solutions to the gaps that we see, things that people don't know. Also educating the community and engaging our legislative representatives so that they can bring more funding to us. They can support us as we go forward. Another area of that we're looking to focus on with our theory of impact is technology and social services. How do we partner more with the community-based organizations that support early intervention? And how do we have a good referral system in place? How do we leverage the resources of our partners in the community to support the work that we do internally? And there's also the fact that a lot of the services that Roxanne provides and Healthy Steps, you asked me, is it's a program for 0 to 3, and it's an early intervention program that is supplementing pediatric care inside our network. So the implementation grant that is starting, it started actually this January for 18 months, is supporting Roxanne's program, Healthy Families, Healthy Steps, Centering Pregnancy, the education piece, as well as helping us reach new funding and to really bring more resources to bear on the issues that we're facing and what we can do, what's within our grasp to do, and to move the needle on the issues that are faced by maternal moms and children in the communities that we serve. I know that was a lot.
Thank you for that answer. Okay, so we've got some more time. So let's throw out some more questions. Let's talk about a few statistics. So we know that Black women with an advanced degree is more likely to die during childbirth than a white woman with less than a high school diploma. When we hear that statistic, what stands out to you? And I'll throw that to Ms. Willer first. What?
When I was invited to this panel, I started to think about a lot of disparities within our community, even with high celebrities. For example, Serena Williams. We know how great she is. We know how phenomenal she is in the tennis world. And, she gave birth to her daughter, and she had to advocate for herself to let them know that something is not right with me. And then even though she kept telling them, like, I don't feel good, something's not right, they still didn't believe her. And she could have easily been one of the statistics. I'm not sure why they look at us differently, and why a woman of color with higher degrees have a higher disparity with women of a white woman, but it's something that needs to be looked at. Is very alarming. Like you said, it dates back into slavery and what they look at us as, just like a baby making system, like wet mommies, where they they breastfeed their slave owners' children. But we have evolved, and it's time for us to take matters in our own hands and advocate for our patients, advocate for ourselves. I always tell my patients, even when you're in a situation, have someone there who could speak up for you. Have someone who's knowledgeable about the medical system and who's not afraid to ask questions and to say, why are you doing this? Why are you doing that? And, force people or get their attention to say, listen, I really don't feel good, and I need you to take full attention of what I'm saying to you. If not, we're going to continue to be a statistic. And I did a project with this, and it's very alarming that 54.1% out of 100,000 moms, African Americans, are dying alarmingly, compared to the 21.1% of the other population. So there's something there that needs to be resolved. I show that they have they put out an $8 million contract to combat this issue, but there's much more to be done. Of course, they try to increase the midwifery services and increase, a lot of personnel in the midwifery department. But again, it also correlates with looking at the real issue of why we are seeing this alarming rate.
Thank you so much for that. Dr. McCullough, I'll ask you this question. So we know that the majority of Black women who are dying in childbirth or after childbirth are dying of preventable causes or conditions. As a provider who's working to make this change, what can we do? How can we change the statistics as they are?
Mhm. Thank you very much for that question. The issues surrounding maternal mortality or morbidity is very complicated. There are, racial biases, there are discriminations, there are institutional biases, racism that contribute to these alarming statistics. Some of the causes of maternal mortality specifically includes cardiovascular disease. Well, how do we get cardiovascular disease? We get cardiovascular disease because of our diet, because of obesity, and families not able to get the proper nutrition, the right food. So we end up ingesting a lot of what's termed junk food. And that negatively impacts your health. It negatively impacts your health as far as diabetes, hypertension, cardiovascular disease. And downstream to that is our moms who are getting pregnant, and the complications of pregnancy directly result from these original medical problems, diabetes, hypertension, and cardiovascular disease in general. So yes, we can increase the number of providers, we can increase the number of midwives, which is important, increase the number of doulas, but systemically we have to look deeper at what's causing these disparities, these medical disparities in our communication, in our communities, and how do we address those issues. So there's going to have to be a lot of, not just local intervention by hospitals such as One Brooklyn Health, providers such as us, but also from statewide or policymakers who are addressing these issues of poor nutrition, poverty, and not to mention also stress in our community. So all of these things need to be addressed. It's not just cardiovascular disease. Some of our moms are dying from hemorrhaging. We're addressing those issues, but there are also issues surrounding infection and drug use, opioid use. It's impacting our communities. And these issues need to be addressed globally. But in the absence of partners from state and local government, we're going to have to do our part to make sure that we're getting through to these moms, that we're educating them, to seek care. And our goal at One Brooklyn Health is also not to have these patients come to see us in our hospital, but also to visit these patients where they are in the community, in their home, in their block, so to speak, to make a positive impact. It's not acceptable that we have Black moms dying at 3 times the rate of white and also Hispanic moms. So we have a lot more work to do in addressing this issue. Thank you.
Thank you so much, Dr. McCullough, for answering that question. I have another question, and I think I'll throw it to you, Roxanne. Let's see, what did I want to ask you? Okay, hold on. So how has systemic racism and discrimination that Black mothers and children from a work perspective? How would you answer this question? Or can you answer this question?
All right. Wow. I can just speak to, what we see on the ground, right? Systemic racism, I mean, it affects their ability to access services. It affects their economic status, their finances, their housing, and it impacts how, how they're treated, how they're treated by service providers. It affects their ability to handle stress, and the way that they present in clinic settings, in hospitals, and in other areas, which may make it difficult for someone will have to work a little bit harder to be able to communicate, to reach them, to just be able to hear them. I think we lost Shalon. But there are just so many issues systematically that impact maternal child health outcomes in the community. And I think Dr. McCullough spoke to a lot of them when he spoke initially. So, some of the things that we do is we do an assessment to see, what are some of the challenges that they're facing, but we also want to look at their strengths, right? Because those are the things, their protective factors, which will help us to be able to address their challenges. Because each person is unique and they come with their own unique strengths and their own unique challenges. And we build a service plan to address their unique issues, connect them with the resources that they need. We try to identify resources in the community that's available. We've worked with Jackie to get cash cards in the past from Robinhood to help alleviate, some of the financial issues that they were addressing. We've worked with external affairs to bring food, to do clothing drives. Sometimes people can't even come out for appointments because of transportation issues. So being able to provide services in the home to someone who is either pregnant in their third trimester or with a young baby, with an infant, that's also really helpful. So yeah, just even providing early childhood services, assessments for children with developmental issues can be a challenge in this community. And I know Jackie has been working with Healthy Steps in more detail around this as well. But many service providers don't want to come to the homes in the community, in our community. So these services, they're not available. And even for mental health, the first challenge is getting someone to be able to accept a referral for mental health services. The second challenge is finding someone who is available to provide services without them being on a wait list, making sure that they have the insurance to provide a service. And then once they get in, a lot of times they're finding that the person that they're matched with is not culturally responsive to their issues. So there's so many different directions I can go with this, Shalon, but for the sake of time, I'll just yield to someone else.
Thank you so much. That was really helpful. That was helpful. Made a lot of good points, just in terms of having people that are culturally responsive and just kind of meeting the needs and meeting people where they are, which is great. This next question, I'm going to throw out to you, Ashley, but anyone else can try to chime in if they have something else to share. What role do cultural beliefs and practices play in shaping Black women's experiences with maternal and child health care?
Well, it's cultural competence and cultural, area issues in general are a big, we really need to know how to understand and address different cultures. And I believe competence is essential, and understanding that, yes, we may be, majority Black African American, maybe from the Middle East, Hispanic, but to understand that, not everyone is the same, and we need to treat each person as an individual. And a part of Baby Friendly is really building that rapport, asking those open-ended questions, quality communication, to find out how can we help this person meet their goals. Now, sometimes depending on where they're from, they might have certain beliefs about breastfeeding that is scientifically not, true. They may believe, some cultures, they believe colostrum, you shouldn't feed the baby colostrum because there's, you should discard that milk. They have some people, who believe that, formula is just as good as, breastfeeding, but we can't say to them, oh, this is wrong. We have to come to them in a quality communication way, in a very sensitive way, asking them open-ended questions, finding out more about, what do you know about breastfeeding? Do you have anybody to support you? Do you have anyone in your family that breastfeed? What is your history? You have any family history with breastfeeding? Find out all these different things can really help tailor a person's education and help them with their infant feeding goals. So it's definitely important that we do culturally understand people. And I think we have to look within ourselves as well to understand that there are, some biases that we have that are ingrained into us because of what we see on television, what we were taught, what's in the textbooks. And you can extend this to so many different things of what, Black people have been going through in regards to, not being able to be diagnosed with mastitis appropriately because of their skin. Some of the textbooks you see, white woman's breast versus, a Black woman's breast, and it doesn't present the same way. So understanding that people present illnesses in a different way through the way they communicate, through the way it appears on their physical body is essential for all of us to learn this and understand this, and to really seek the resources to make sure that we're helping everyone regardless of their background, their race, and their culture.
Thank you so much for that. That's a great answer, Ashley. And you brought up some great points, just even basic things like understanding how to diagnose the patients that we're working with based on their color of their skin, and taking for granted that that's something that's across the board. So that's great. So we have a few more minutes. I have another question that I wanted to give to Jackie, but if there's anyone else that has some other that they can share towards this question, you can feel free to chime in. Jackie, what would you say are some, working in what you do with maternal child health, what are some of the most promising and innovative programs or initiatives aimed at improving Black maternal and child health outcomes? And how can they be scaled or replicated in other communities?
Thank you for the question, Siobhan. What I think the most optimistic thing that we have going right now is the fact that a number of you described the social determinants of health as really the drivers of outcomes for women. And that has been established that if you can address housing, if you can address the crime issues, if you can take the stresses away from a woman's life and more broadly from Black families' lives, the health will be better. If you can educate about food and nutrition, if you can bring them to understand that, hey, going to the doctor is something that is okay to do. Seeking prenatal care very early on in your pregnancy is critical to having a good outcome. So there is the recognition that's going on that social determinants of health need to be addressed to give us good outcomes in the healthcare system and to drive down the cost, because a lot of the impacts of the social determinants of health result in higher costs for us. You have more crime, that's more ER use. You have more, babies being kept longer in the hospital because of a bad outcome. So I think it's sinking in, and it's at the highest levels, even on the federal level, that if you address the social determinants of health, if you invest money in housing, in crime prevention, in taking down the temperature in communities, the stressors, if you educate the public, if you tell them more about, say, vaccinations, a hot button issue, vaccinations, if you tell them more about, get people more educated about obesity, get people more educated about good nutrition, then it's a win-win for society. It's a win-win for the healthcare system. God knows, all you've heard about in the past how many years is the cost of healthcare. We know how much we pay. We know how much, we hang on to a job because of the healthcare. It's so critical for us. But if you can really address a lot of the things that result in disease, then you're driving down the cost. You have less stress on doctors. You have less stress on the system. So as a glimmer of hope, it's really great that foundations like the Robin Hood Foundation, who is funding the maternal child health, they were willing to sit with us and go there with us, take us to a planning year, give us a full $500,000 to do some planning. And then they came back and said, oh, we're going to fund you for $1.3 million for 18 months. And let's see what you can impact in the community. At the same time, you have our legislators in Albany, in the city council, and on the federal level, who are looking at us as, we're drivers in the communities that we serve. We are anchor institutions. So our role is beyond just providing healthcare and ER and, services, but in working with community leaders to have an impact on, good housing, having an impact on, activities that lead to good health, like exercise and just a whole bunch of things that impact health. So I think that, there is to use a word, there is a wokeness going on about healthcare, and especially the healthcare of African-American folks in this country, that we've been, underfunded. We live in communities with no money. Our hospitals don't get the funding that they deserve. We're always, going out with hat in hand. I think we're at a good time. And if we can really leverage the moment, I should say, the fact that all eyes are on this, and if we can really, use the power of social media, the power of, what we have in our communities, then I think I'm very hopeful. I think we have cause to be hopeful.
We're all doing a really
thank you so much.
job.
If I may, Shalanda, I would just add a couple of statistics to what Jackie just spoke about. If we look at the maternal mortality rate in the United States for 2020, if you look at women who are under the age of 25, their rate was 14%. In the age group of 25 to 39, that was 23 per, not percent, but per 100,000 women given birth. And if you look at the population over 40, that was 108 per 100,000. So we're talking about fivefold if you're over the age of 40. So there has to be specific and direct attention paid to that particular age group if we're going to make a significant impact on maternal mortality and morbidity. And morbidity is also very important because, when you have one maternal mortality, there are probably 10 close calls associated with that one mortality. So there's a lot of work to be done, and we have to pay attention to this age group, women over the age of 40, who are 5 times more likely to die in childbirth than someone who's less than 25 years of age.
And
Thank you so much.
If I may just add, Shalon, to what Dr. McCullough said, it's while we have some things that are specific to maternal morbidity, the reasons why, if we broaden the lens and we look at, the causes of health inequity in the system, I think that, and then we make the changes as we find out, what we study the issue, we figure out how it is that we can address them. I think that will go a long way in improving outcomes for us. To make you aware, we are working with SUNY Downstate to develop the Brooklyn Health Equity Index. We secured funding from the New York State Health Foundation last year, and we're developing the index. We're engaging a lot of the community, and it's really this tool is going to be driven by our patients. Their input will matter. We'll tell them that, getting that buy-in from our patients is very important in, moving forward and changing the trajectory of where we are. So this index is in the pilot. You'll probably hear about it. It's in the piloting phase. And the hope is that we will develop this. It'll become a part of, how we do business, that we're always, inviting the views of the patient and hearing them. And this is very specific to discrimination, whether it's, in the ER, at visits, and whether it's a perception or reality. We want to hear about it so that we can make changes, where appropriate.
I think another area where,
Thank you so much.
Another area that we're stepping into that will make a huge difference in the trajectory is that we're looking at a whole person. We're looking at the family as a whole. We're looking at their physical issues, their social issues, their mental health issues, and that we're addressing it using a multidisciplinary approach. So the issues that we're addressing, they're multifaceted, and so we have to work together across professions. And this was mentioned in the previous training that we attended. But it's true, we have to work together. No one entity can address all of the issues successfully without us working together.
Shared responsibility.
Mm-hmm.
Did we lose Shalon?
So thank you.
Are you there?
For a second. Thank you for all those questions. I'm here. Can you hear me?
Yes, we can see.
Okay. I am here. I think all of you answered some great questions. I know we need to wrap it up. I think what we've learned from this discussion is education is key. We need to understand the foundation and the behind, right, a lot of the disparities that exist. We need to address them and know that they do exist and acknowledge that they exist. And we need to understand where people are coming from, why they believe, why do people not come to the doctor, why do people not do, and understand the history of things like this Tuskegee experiments and Henrietta Lacks, and just all the different ways that Black bodies have been used as experimentation, and understanding the mindset of Black people when they choose to get healthcare or seek healthcare, or why they choose not to seek healthcare. I think as a community, I think what we realize is we need to work as a community and come together to make a lot of these things and changes happen. So I hope this was helpful for all of you who are watching this afternoon. We are going to get up later for some questions, but I want to first thank all of our panelists. I want to thank Dr. McCullough. I want to thank Roxanne Monroe, Deirdre Willer, Ashley Orenstein, and Jackie Burley. Thank you so much for being a part of this panel. Thank you so much for sharing wisdom and insight with us. And we hope that this is not the end, but only the beginning of dealing with the what exists with maternal child healthcare. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank you, Shalon.